So the spinal deformity study group, they also classified as low grade spondylolisthesis, that is grade 0, 1 and 2, or that is less than 50% of slippage. Type 1, it is known as the nutcracker, a subgroup with low uh, prevalence of less than this angle 45 degree. Then type 2, a subgroup with a normal PI, it is between 45 degree and 60 degree. And type 3, a share type subgroup with high PI, that is more than 60 degree. Then other type is high grade spondylolisthesis, that is grade 3 and 4 spondyloptosis, or greater than equal to 50% of slippage. Each case must first be classified as if presenting a balanced or unbalanced sacropelvic using the values of PI and the SS. The spinopelvic balance is determined with the use of plumb line of C7. If this line falls on or behind the femoral head, the column will be balanced. If it falls in front of the femoral head, the column will be unbalanced. Now, low-grade spondylolisthesis type 1, those patients with low PI and SS may be present clamping of the posterior elements of L5 between L4 and S1 during extension, which is eventually an effect seen in the nutcracker or in the pars articularis of L5. Type 3 is patients with high PI and a sacral slope, which shows an increase in the shear forces incident at the lumbosacral junction, which causes further tension of the pars articularis. Now, talking about the balanced and the unbalanced pelvis, patients in the group unbalanced include those who in the orthostatic position have retroverted pelvis and verticalized sacrum, which corresponds to low SS and high PI. It has also been shown that patients with high degree of vertebral slippage have a mean PI of greater than 60 degree. Increased PI is associated uh, with increased lumbar lordosis, which predisposes to mechanical changes of the lumbar and lumbosacral junction and increase the risk of spondylolisthesis. This contrasts with those of the low-grade spondylolisthesis in whom PI values are low, normal, or high. The spinal pelvic balance is determined with the use of plumb line of C7. So if this line falls on or behind the femoral head, we think to be disbalanced, but if it falls in front of the femoral head, then it is unbalanced. The sagittal balance is the measurement of C7 plumb line over from upper posterior border of S1. This line should pass through the superior end plate of S1, or more precisely within 2 cm of the posterior superior corner of the S1 vertebral body. The position of the line is termed as positive, neutral, or negative according to its distance from the posterior superior corner of S1. Sagittal balance was significantly increased more than 3 cm in those with retroverted posture unbalance. This suggests that the positive sagittal imbalance may be associated with this type of spinopelvic alignment. So you can see low PI, normal, high PI, balanced pelvis, retroverted, unbalanced. It is the low grade and the high grade spondylolisthesis. So this is one modified Newman spondylolisthesis grading system. The degree of the slip is measured by two numbers. One along the sacral end plate, second along the anterior portion of the sacrum. Okay, so what are the risk factors for the progression? If it is at presentation is at the young age, that is diagnosed before adolescent, and females are more prone A sleep angle of more than 10 degrees is increased pelvic incidence. High grade sleep greater than 50%. Dome shaped or significantly inclined sacrum, that is the SDSG index is if it is more than 25 percentage. The natural history is predominantly determined by developmental or acquired spondylolisthesis, low or high dysplasia, quality of pedicle, the parts and the facets of the vertebra, the age when the diagnosis is made, degree of lordosis and position of the gravity line, degree of secondary or remodel deformity, competency, hydration and height of the disc. In natural history, in case of dysplastic spondylolisthesis, it is seen in early age, usually asymptomatic, and severe sleep is seen between 9 to 15 or after 20 years. Risk of neurological complications is there, higher risk of sleep progression, that is cauda equina syndrome, as the neural arc is intact. Natural history of ischemic spondylolisthesis, that is we can see no progression of sleep, no progression of sleep, we can see less than 10% displacement, asymptomatic, no progression after adulthood, no backache later in life. But in progression of sleep, it is more than 25% of the sleep age, it is symptomatic, risk of sleep progression is more, backache is seen in the later life. Natural history of degenerative spondylolisthesis, we see it is rarely seen before 50. And Matsunaga et al. 10 years prospective study. In this study, they found that 34% of the population showed progression of the slippage, though no significant effect was seen in the clinical outcome. There were further disc space narrowing continued in those without sleep. Back pain has improved, that is called auto-stabilization. 83 of the patients with neurological signs and symptoms deteriorated. Clinical evaluation of spondylolisthesis. Spondylolisthesis, usually asymptomatic incidental finding in X-ray. Symptoms depend on the severity of the slip and is caused by chronic muscle spasm. Body limits the motion around a painful pseudoarthrosis of facet and its spars. There will be tears in the annulus fibrosis of the degenerated discs, compression of the nerve roots. Clinical evaluations when asymptomatic in children and young adults. Back fatigue and back pain on movement, that is hyperextension due to instability of the affected segment, hamstring fatigue and pain due to irritation of L5 nerve root, sciatica may occur in one or bilateral. Clinical evaluation in patients more than 50 years, there will be backache, sciatica, pseudoclaudication, spinal stenosis when subluxation is severe, there will be stenosis of the canal. Other signs of the are nerve root compression, motor weakness, reflex changes and sensory deficits. Clinical evaluation, compression of the central canal, there will be disturbances of bladder and bowel, bilateral leg symptoms, there will be positive straight leg raising test bilaterally, there will be positive crossed SLRT. On inspection, the buttocks it is seen as flat, heart-shaped in high-grade sleep, sacral prominence, sacrum is more vertical, appears to extend to the waist, lumbar hyperlordosis above the level of the slip to compensate for the displacements, there will be hyperlordosis, transverse loin crease, with severity there will be absence of waistline, peculiar spastic gait will be there in the patient due to hamstring tightness and lumbosacral kyphosis. This is important. A lumbar hyperlordosis, transverse loin crease and absence of waistline. clinical evaluation, scoliosis is seen especially in children 3 years. The sciatic lumbar curve is caused by the muscle spasm that results in symptoms. There will be Holisthetic due to asymmetrical slipping of vertebra, idiopathic. In holisthetic crisis with total canal occlusion or blockage, typical posture decrease nerve root tension by supporting trunk with hands on knee, and in spondyloptosis there will be shortening of the lumbar spine. This is the clinical evaluation. The patient keeps the hands on the knee. So this is the holisthetic crisis, typical posture. And decrease the nerve root tension, the patient supports with the trunk with the hands on the knee. So this is the picture. Then the clinical evaluation on palpation, palpable step tenderness over pars defect, hamstring tightness on leg raising will be found. Movements usually will be normal in young patients but maybe hamstring plus paraspinal muscle tightness. Limiting forward bending and hip flexion can be seen. In the degenerative type, often the spine is seen very stiff. Positive nerve root tests if root compression is there. There will be pain generators, leg pain like L5 compression, traction, abnormal motion, facet joint arthrosis, pars scar, the disc above, far lateral disc, and the radiographs imaging anterior posterior view, standing lateral view, which includes the hips, oblique view helps in viewing the pars interarticularis defect, as we have discussed in the beginning, had a Scotty dog appearance. Then there will be the lateral flexion and extension view. Then flexion extension lateral view, which may reveal instability considered to be present when 4 mm of translation or 10 degrees of sagittal rotation greater than the adjacent level is identified. Then Ferguson view, it depicts the L5 pedicles, transverse processes and the sacral ala more clearly. So these are the imaging techniques. This is the Ferguson view, 20 degrees cordocephalic anterior posterior view. See, this is the radiographs, this is the flexion extension x-rays. This X-ray demonstrates a bilateral break in the pars interarticularis or spondylolisthesis. There is a lucent image, or lucent is shown by the black arrow here, and that allows the alpha vertebral body red color arrow to slip onwards on the S1 vertebral body blue arrow. So the blue arrow is the S1 vertebral body, red is L5 vertebral body. This black color arrow depicts the lucency, that is the break in the pars interarticularis. Bilaterally there is a break, and this results in the forward slippage of the L5 vertebral body over the S1 vertebral body. And also there is inverted Napoleon's hat sign. Just for your knowledge, we don't have to go that much into details, but yes, you should know that if you come across some X-ray like this, then you should be able to know what is inverted Napoleon's hat. That indicates the presence of bilateral spondylosis and significant spondylolisthesis. The dome of the hat is formed by the overlying body of L5 vertebra, and the brim is formed by the transverse processes. So now we have come to the most important aspect, which is very popular and common. We should know, that is the Scotty dog sign on the AP or anterior oblique views of the X-ray. Now see here, this is the dog appearance, this is the neck of the dog, and this is the break here. This is the pars interarticularis, the neck, if the collar. So if the neck is broken, neck of the dog, imaginary dog, then you can see there is the translation of the vertebra going away from the original position. So here also, if you see in the X-ray, this is the dog like appearance given by the dotted lines to to better understand. Then the other investigations we go for CT scan, MRI, for the evaluation of the spinal stenosis, and may also reveal us the facet overgrowth, the hypertrophy of the ligamentum flavum, and the disc herniation, tumors, the SPECT. Another type of investigations is sensitive for impending spondylolisthesis, high resolution CT, NCB, EMG, arterial Doppler CT angiography are some of the other investigations. Now the SPECT is called the single photon emission computed tomography, is necessary to show whether the uptake is increased in the pars, which is helpful in determining whether the process is acute or chronic. If the increased uptake is confirmed, a CT scan can be obtained to evaluate whether there are thickened cortices consistent with a stress reaction or whether there is an acute stress fracture. MRI allows for additional visualization of the soft tissue and the neural structures and is recommended in all cases associated with neurological findings. In the early course of the disease, MRI helps in identifying the stress reaction at the pars interarticularis before the end stage bony defect. MRI may show the degree of impingement of neural elements by fibrous scar tissue at the spondylolytic defect. Then also the MRI shows the status of the disc. So this is the disc degeneration shown by MRI. So here you can see the lumbar MRI showing the spondylolisthesis as L4, L5 level. Now if you see here the L4, L5 level, there is the shift of L5 vertebra due to degenerated disc at the L4, L5. Loss of smooth lumbar curve can also be seen clearly. The L5 is shifted. Can you see? So this is the L4, L5. The L5 is little bit shifted and the loss of smooth lumbar curve can also be seen clearly. Now this sleep angle is an angle formed between the line perpendicular to the posterior aspect of the upper sacrum and the line parallel to the L5 inferior or superior end plate. So this is the perpendicular line to the posterior aspect of the upper sacrum and the line parallel to the L5 inferior superior end plate, and this is the sleep angle formed here, which is shown here 38 degree. Angle greater than 30 degrees is associated with greater risk of sleep progression, instability and development of postoperative pseudoarthrosis. It is the best predictor of progression of the slippage. The sleep angle greater than 55 is associated with a high probability and increased rate of progression. PI, pelvic incidence. A line perpendicular to the midpoint of the sacral end plate is drawn. A second line connecting the same sacral midpoint and the center of the femoral head is drawn. The angle subtended by these lines is the pelvic incidence. So here is the a line perpendicular to the midpoint of the sacral end plate is drawn. Second line connecting the same sacral midpoint and the center of the femoral head is drawn, and center of the femoral head is drawn. The angle subtended by length is the pelvic incidence. The pelvic incidence is equal to pelvic tilt plus the sacral slope. So this is the pelvic tilt here. This angle from the sacrum to the femoral head, and this is from the pelvis. This is the sacral slope, the superior part of the sacral, and the inferior part. This is the sacral slope angle. This is the pelvic tilt. This is the pelvic incidence. So pelvic incidence is calculated by the pelvic tilt plus the sacral slope. Normal it is 50 degrees. And the increased pelvic incidence may predispose to spondylolisthesis. It is seen in degenerative and dysplastic cases. So do not get confused, or do not go into much of uh, complication. Just you remember the indicators for how we measure. One is the slip angle, which is already we have seen this slip angle, how it is formed, these lines 30 degree, and the other is the pelvic incidence. Just you try to understand basic is that uh, a line perpendicular to the midpoint of the sacral end plate, a second line connecting the same at the center of the femoral heads. This line is subtended and is the pelvic incidence. So if it is more than 50, increased PI may predispose to spondylolisthesis. Pelvic tilt, a line from the midpoint of the sacral end is drawn to the center of the femoral head. The angle subtended between this line and the vertical reference line is the pelvic tilt. Higher pelvic tilt predisposes to spondylolisthesis. So this is the vertical reference. This is the midpoint of the sacral end plate drawn to the center of the femoral head. Okay. And other is from the vertebra to the femoral head. So this angle is between this line and the vertical reference. The vertical reference line is the pelvic tilt. Higher the pelvic tilt, it predisposes to spondylolisthesis. Sacral slope, a line parallel to the sacral end plate is drawn. The angle between this line and the horizontal reference line is the sacral. This is the line the parallel to the sacral end plate, and the other line is the horizontal reference line. This is the angle. This is the sacral slope. Sacral slope and the pelvic tilt together, when we add, will give the pelvic incidence. So now Mayarding X-ray grading of spondylolisthesis. According to this grading, percentage of slipping calculated by measurement of distance from the line parallel to the posterior portion of the first sacral vertebra and body to the line parallel to the posterior portion of the body of the L5. Anterior posterior dimension of L5 is inferiorly is used to calculate the percentage of slipping. So first it is the measurement of distance from the line parallel to the posterior portion of the first sacral vertebral body. So this is the first sacral vertebral body. This is the line parallel to the posterior portion of the sacral vertebral body to the line parallel to the posterior portion of the body of the L5, the anterior posterior dimension of L5. infrequently used to calculate. So grade 1 is displacement of 25% or less, grade 2 between 25 and 50, grade 3 between 50 and 75, grade 4 more than 75, and grade 5 represents the completely below the top of the sacrum, that is called the spondylolisthesis. So the risk factors is growing years. It is in the growing years of 9 to 15 years when the bones are growing and when the ossification is taking place. Girls are more prone to boys. It is asymptomatic posterior, postural or gait abnormality is seen. Radiographic type 1, we see dysplastic vertical sacrum, 50% of more than 50% slippage, increased sleep angle, instability of the flexor extensor views. Now, we have seen many things about the X-ray, the Scotty dog, what are the grades of the slippage, what happens in the spondylolisthesis, and what are the radiological parameters of this sacral slope and the uh, pelvic tilt. And when we take both these, we can come out with the pelvic incidence ratio, and we can calculate also the Meyerding classification of the X-ray. So we have got some idea about the spondylolisthesis. So now, what is the treatment? Actually, it is the repair of the pars interarticularis is the operative treatment. The patient remain asymptomatic for more than 3 months with conservative treatment. Non-union of pars, there is non-union. So that is the indications. Prerequisites is absence of spondylolisthesis, absent degenerative changes of disc and facet joint, so absence of dysplastic changes on MRI and CTs. So this is for the treatment of spondylosis. So this is the non-operative. That is treatment is avoidance of sports and high other intensity exercises. Rehab with the strengthening of the abdominal paraspinal musculature, minimization of pelvic tilt, anti-lordotic bracing, all these things. And then the operative procedure is to the repair of the pars interarticularis. Now, the repair of the spondylolytic defect also is called the buck technique. The repair of the pars interarticular defect is done by pedicle screw insertion and bone grafting. It is the Scott wiring and modified Scott technique. Also, Kakiuchi procedure will repair an ipsilateral pedicle screw and hook. So you just have to know these names. We don't have to go into too much of details of the surgeries. This is the Scott technique. Actually, here a stainless steel wire is looped from the transverse processes to the spinous process of the level involved and tightened in conjunction with the local iliac crest bone graft. This wire creates a tension band construct, placing the pars defect under compression and holds the bone in graft in place. So this is the Scott technique. This is the Scott wire. It is inserted from the transverse processes to the spinous process of the level involved, tightened, and creates a tension band construct. So you can see here it is inserted from both the transverse process and coming to the spinous process. It is holding the pars or it is compressing the pars, giving stability. This is the modified Scott technique. Wire is passed around the cortical screws introduced into both the pedicles and tightening beneath the spinous process. So biomechanically it shows that this fixation of the wire at the pedicle does not increase the system of stiffness of the system. This technique have defect of healing rates of 86 to 100%. Modified Scott technique. Then Kakiuchi technique. It is reported to be successful union of the pars defect with the use of a pedicle screw, laminar hook and a rod system. Pedicle screw, laminar hook and the rod system. You can see in the X-ray here. Ultimately, we have to stabilize the pars the area. So the pedicle screw is placed in the pedicle above the pars defect. The pars defect is bone grafted. Rod is placed in the pedicle screw and then into the caudal laminar hook and compression is applied. This gives a more stable construct than afforded wired techniques. So this Kakiuchi technique is reported to be a successful union of pars defects. It is the management of ischemic spondylolisthesis non-operative. If a patient has spondylolisthesis of more than 1 or 2 millimeter, no orthosis is required and healing is unlikely. If no neurological symptom, brief period of rest and anti-inflammatory medication, muscle relaxant, and then low impact aerobic exercise, trunk stabilization, avoiding extension and hamstring stretching is done for activity of after 8 to 12 weeks. And the operative treatment indications are the persistent symptoms despite 9 months to 1 year of conservative treatment, tight hamstrings, abnormal gait, pelvic trunk deformity, development of a neurological deficit, and then in a skeletally immature patient with slippage greater than 50 or mature adolescent so with more than 75, even if the patient is asymptomatic, this is one of the indication. Pars defect of more than 1 to 2 millimeters is another indication. Before surgery, patient is assessed for global balance by standing lateral and AP radiographs was checked. Slip angle, sacral and the plate morphology. L5 transverse process should have 2 centimeter surface area. MRI for reticular symptom and this assessment is done. Surgical goals are to address the pars defect and the rattler loose laminar arch, decompress the foraminal stenosis. If there is a compression in the foramina, you have to release that, address the degenerative disc. If the discs are already degenerated and damaged, that should be addressed and addressed to the overall dynamic stability of the motion segment. These are some of the instrumental posterolateral fusion uh, interbody spacer devices, and then the surgical procedures. We don't have to go into much details. Just remember the procedure names and what is the goal, how, which are the things done. So you can see here pedicle screw fixation with bone grafting done here. These three areas, these screws and bone grafting is done, and then you have the posterior or lumbar interbody fusion. So this is another type of procedure called the lumbar body fusion. So this is another surgical procedure which is done for by the fusion of the lumbar interbodies, and then also we can see this is the PLIF technique, laminectomy, discectomy, and these are the implants used. Bone graft and interbody case, vertebral spreader is used to widen the disc space. So this is again one of the result done where it was completely, the slippage here lying in front of the sacrum here. The L5 has come far away. Here after the surgery, this is the implants, screws fixed and the alignment is done. Also there is another procedure called transforaminal interbody fusion. This is the transforaminal interbody fusion. This is the comparison between PLIF versus TLIF. Anterior lumbar interbody fusion. So there are lots of surgical procedures, and the main goal is to stabilize the vertebral segments. And here biomechanically superior large area fusion grafts under compressive loads, degenerative disc is removed, and then ultimately decompression. This is the direct pedicular body fixation. Instrumented reduction and fixation. Decompression and intra-body fibular graft fixation for spondylolisthesis. Some complications like pseudoarthrosis, most commonly seen in more in smoker, and a preoperative large sleep angle, high-grade translational deformity, uncorrected segmental kyphosis, neurological deficit injury during the dissection, and sometimes compromised nerve root. So it's a bit sometimes risky, these whole procedures, vascular complications, and sometimes infection. So this is generally we have seen about the spondylolisthesis, and why spondylolisthesis happens because of the spondylolysis. And to treat the spondylolysis, we have seen a number of surgical procedures. Just go through these procedures. Try to remember the surgical names and one or two line if you can write about those names, and we don't have to describe the procedure. Maybe you can write the name of the grop technique, and you can write about the interbody fusions, the anterior lumbar interbody fusion. Then you can write about the transforaminal interbody fusion, TLIF. You can write about the posterior lumbar interbody fusion, and one line what is the goal and how it is done, and then the operative treatment indications as we have discussed, and the surgical goals. We have to write the surgical goals, which is very important, because ultimately what is the goal of the different procedures which we have seen? The goal is to address the pars defect, to decompress the foraminal stenosis, to address the degenerated disc, and to address the dynamic stability. So this is something about this spondylolisthesis, and also we will try to see about spinal stenosis. Okay, thank you for your patience, and I hope you'll get some idea. Any doubts, please feel free to discuss. Thank you.